that directed me in that field, and to be practicing with mainly with track and field athletes.
So let me see. We're going to switch direction here a little bit. Many athletes will avoid doctors because they fear being told to take time off, being forced to take time off from their sport with surgery. What is your goal as a physician?
My goal as a physician, as a sports medicine physician, is simple. I want to get active people back to their activity as quickly and as safely as possible. Done. And it's I do, having been an athlete at that high level for a while, I understand that, where you don't want to give up what you love. And I think that I try to bring that to my conversations with my patients, whether that is an Olympic athlete or a grandma who just twisted her knee. You know, it's getting that understanding of, yeah, there are things you want to get back to doing that you can't do, but you also don't want to be told, you got to put this down. Let's see how we can work together to get you back to the activities that you want to do as safely and as quickly as possible.
And that's great, because I think that's a lot different than a lot of people's mindset of, well, just an athlete's mindset of they don't want to take any time off. But if they're hearing that, and this is going to apply for anybody that in practice of any type of sports medicine, is that we do want to get you out there as quickly as possible. And I just want to make sure you're healthy when you do go back out there.
Yeah.
So as part of the treatments you do in trying to speed up the process, and I was watching the TED Talk you did back in 2013 about regenerative therapies, such as PRP and BMAC. I think most of us have heard of platelet-rich plasma, and we will get to that in a moment. But could you tell us more about BMAC first?
Yeah, I think kind of the umbrella of biologic modalities of treatment. I think that in talking about biologics, you have to frame this in what they are and what they are not. What they are growth factors, cells, enzymes that are taken from your body and given back to you to try to speed up a process that is stalled. Okay. What they are not a panacea. They do not cure they don't cure a disease that we don't have a cure for. They can't cure arthritis. They can't repair a completely torn ligament. They can't regenerate things indiscriminately. And so BMAC, it's bone marrow aspirate concentrate. It is an aspiration of, it's a concentration of bone marrow that has been aspirated usually from the back of the hip or that iliac crest and concentrated. And then that concentrate is injected into a site that you would like to accelerate the healing process on. And that injection usually should be done under ultrasound guidance so you can know that you are injecting in the correct spot and you're putting these growth factors, these cells in the place that you specifically want them to act.
Are these going to be similar sites that you would use PRP with, types of tissue?
Yes and no. From my with my practice, I tend to use PRP a lot for tendons because tendons tend to have, the issue with a tendon is it doesn't have a great blood supply. So you're bringing with the PRP, you're bringing the growth factors that the blood would normally bring, but the cells are there and you should be able to accentuate the process that would that has slowed down. BMAC I tend to use in areas where you are lacking cells, or you're lacking the tissue, or you need a cellular component to be there. So when you're talking about being in a joint where you don't have the cells that are readily available, or when you're talking about in a muscle where there is a significant amount of damage or defect, you need additional cells to be in that area. That would be where I would, how I would kind of draw my line between PRP and BMAC.
Okay. Excellent. So PRP gets a bad rap for its rate of effectiveness, or it has. I've heard this before. Maybe it's been a little while, but it sounds like success rate depends on who you're treating, what you're treating, and even where the treatment takes place in regards to the injury site. Would you talk about when you see PRP being effective, when it tends not to be?
Yeah, I think there are a number of issues with PRP in that when you talk about PRP, a lot of people aren't comparing apples to apples, because there's PRP, there's platelet poor plasma, there's autologous conditioned plasma, a lot of different things that come under the umbrella of generic PRP. When you look at the studies that compare platelet-rich plasma with leukocytes or without leukocytes, with red blood cells or without red blood cells, and you're comparing apples to apples, things do tend to fall out pretty nicely in that lateral epicondyle, excellent results. So tennis elbow, excellent results with PRP. With Achilles tendonitis, not as great results, but good, consistent results, and not necessarily with a single injection. It may take repeated injections. Patella tendonitis, that's where you begin to get a lot more variation, even when you're using the same preparation and the same technique. Rotator cuff tendinopathy or partial rotator cuff tears, that also tends to be a pretty mixed review. And then when you talk about efficacy or effectiveness of PRP, are you talking about is there regrowth of the tissue, or are you talking about patient satisfaction and return to activity? Depending on how you measure success, these treatments can be more or less successful. So you tend to have a better or consistent ability to return to activity after PRP injections, but you don't tend to have as consistent of a regeneration of tissue. And so you get, you're in kind of that gray zone of, okay, if you don't have the tissue regenerated and completely healed and back to normal, why is the patient then able to get back to their activity? Is this just placebo effect, or are there some biomechanical or biochemical attributes that are being accentuated that allows for partially healed or defective tissue to function as normal? We don't know the answer to that yet.
And so I'm hearing that where it's less effective tends to be more lower extremity. Is there a relation with kind of it's harder to really rest kind of lower extremity because just you need to be mobile as opposed to more upper extremity?
That is truthfully one of the things that we wrestle with. It's the why behind it. Yes, that definitely is one a portion of, can you rest it adequately? But there is a school of thought when you're talking about biologics that you don't necessarily want to rest it completely. You want to do the appropriate type of activation, because musculoskeletal tissue, when you stress it appropriately, you can augment or accentuate healing processes. It's when you overstress that you get in that area. I think yes, it is the inability to give it a rest, but also it is the composition and the loading type of the tendon, because the patella tendon is loaded in a slightly different way than the Achilles, but the Achilles and the Achilles works better, responds better to PRP than the patella does, the patella tendon does. And is it because it has a larger muscular component to it, and you have a myotendinous junction that can give some accentuated growth factors? Don't know, but yeah, I do agree that a part of this is because the lower extremity, or the portion, the places on the lower extremity that don't do as well, you can't immobilize or support as well as you're going through the rehab process.
Gotcha. Uh, Now, as a non-operative orthopedist, you're looking for all different ways that you can treat injuries for the people that come in. What other tools are you using, or what other things are you using for treatment?
For treatment, it's the, I think from, I think the biggest thing that I use are people like you, Tom, the massage therapist, the physical therapist, who once I get the diagnosis and say, okay, this is what's going on, I have a source, or a referral source at Emory to talk to and refer people to say, okay, this is what I would like to get addressed. And I'm confident that they will do the appropriate modalities and interventions to get the treatment done. For most of the time, it's the diagnostics and making sure that I have the appropriate diagnostics diagnosis made in referring, and that is where I find musculoskeletal ultrasound to be a huge advantage. The being able to see tissue specifically down to the a muscle fiber or tendon fiber level, or ligament fiber level, being able to do diagnostic exams and being able to do them at point of service, where if they have a pain in a specific area, I can look at that area specifically, have them move, reproduce the function that is causing pain, and be able to get a dynamic evaluation. And then being able to then say to my interventional partners, saying, look, this is what I found, and give them the direction that then they can use the tools that they use to treat and get people back. Because a lot of times I say it's my physical therapists, massage therapists, athletic trainers, they make me look good. I make the diagnosis and say, here, you guys fix it, and we work well. I have really good partners from a therapy standpoint.
I, personally speaking, I'd like to hear that.
Yes.
You've spent a lot of time on the sidelines of sports also. Being there, you have the opportunity to see how athletes become injured in the context of their injuries. Mm-hmm. How does this help when you bring them into the clinic space?
Yeah, it helps to know what you're seeing and why you're seeing what you're seeing, in that there is, and I think that is part of the reason why when I talk to patients, I say, if you're going to see a physician, if you're going to see a therapist, if you're going to see somebody, you should make sure you go to somebody who is familiar with and understands the sport that you are that you were injured from, the activity that you were injured from, because understanding what are the forces, the mechanics of the injury helps you to then understand what could potentially be injured and what then needs to be fixed and adjusted. And I think that perspective that you have from seeing it live and seeing when it happens is invaluable with then in the office evaluating and seeing what things look like and how things differ. Because we have fellows and residents that we train, and for the most part, they're not on the sidelines very frequently, and they'll just see the patient when it comes into clinic. And what something looks like 24, 48, 72 hours after the initial injury is very different. And what it looks like can also help you to understand, okay, what has or has not happened from injury to this time. Because if you're used to seeing what it looks like when it's initially injured and you see it in the clinic, you can say, oh, there's a lot more swelling than I would have anticipated. Let me be sure that we do some more soft tissue work or some work to get rid of the swelling. Or it doesn't look as swollen as I anticipated. Maybe there's not the same amount of damage that I would have anticipated.
Fascinating.
Mm-hmm.
So getting back to the sidelines, I had the joy of experiencing what I call a game changer, the portable ultrasound you brought to last year's high school track and field champs, and probably a number of years before that. I'm still thinking about how this affects diagnosing, treating, and maybe more importantly, when to tell an athlete to shut it down. Being able to look at injured tissue immediately after an injury, how has this changed sports medicine?
It's, for me, I think it has changed it significantly in that, as you mentioned, I bring that ultrasound with me everywhere. Whenever I'm on a sideline, whenever I'm covering, I always have ultrasound with me because it helps me to be more confident in my diagnosis and my prescription as to, as you mentioned, when they should shut it down, when they should be able to compete, and where things are. Yeah, before ultrasound, was I a competent physician at my diagnosis? Absolutely. And are there people out there who can diagnose without ultrasound? Absolutely. But when I am able to, someone feels a pop or strain in their calf, and I'm able to put my ultrasound on there and look and see that, yeah, their Achilles tendon is, if their Achilles tendon is torn, you don't need the ultrasound for that because everybody can diagnose that. But if someone has a jammed finger and it's really painful, and I don't know if there's a fracture or not, I can use the ultrasound and see, is there a fracture there? If there isn't, we can buddy tape and get the person back. Or if there is a ankle sprain, I can look at the high ankle sprain ligament and see, is that distal syndesmosis disrupted? If it is, we're shutting them down. If it isn't, it's like, okay, we can try taping and let's move forward. I think that things like that, those acute injuries that can lay in the gray zone, could, ultrasound is, for me, vital and indispensable at this point. But as one of my mentors said, he's a team physician at Alabama. I was on the sideline for the SEC championship, and I said, I have musculoskeletal ultrasound. He's like, if I need an ultrasound, I don't need an ultrasound. You know, he has the thing. If we think that the person is going to be, we need to make that distinction in that at those stakes, you might say, yeah, no, we don't really need it. We're going to shut them down anyway. But in the high school setting, in the you are not close to being able to get imaging setting, it can be invaluable in helping you to do some acute treatment and get somebody comfortable or get somebody back playing a little bit more quickly.
So if anybody has not seen a portable ultrasound machine, and you've had ultrasound used on you, you've seen it in the clinic space, and it's on a cart, and it's pretty. I mean, it rolls around, but you're probably not gonna bring it to the sidelines. But this is, you know, actually view images on a iPhone or an iPad, which is really cool.
Yeah.
So, and I just learned late last year that there are now portable X-ray machines on the market.
Mm-hmm.
Have you begun using those, or have you seen those in use yet?
No, I haven't. I have seen those. I haven't started using those mainly because it's radiation. And with that, that's the thing that I like about ultrasound also, in that there is nobody that you can't do an ultrasound on. If there's an infection, if there's an open gaping wound, if there's a pregnant woman, doesn't matter. You can always use ultrasound. And so it is, there aren't that many limitations. The portable x-ray is really great for the high velocity and the potential traumatic injury producing sports, football, hockey, lacrosse, those having portable x-ray at a high school meet can be invaluable when someone hits a hurdle and falls down on their wrist. Do they have a wrist sprain or do they have a wrist fracture? You can definitively diagnose that with a portable x-ray. You can probably diagnose that with a portable ultrasound. And if you have neither, you're going to treat that conservatively and send them off for definitive injury. So it's a good thing to have, but it's a good adjunct to your clinical skills that you have otherwise. But it's not something that you should be reliant or dependent on. Because if my ultrasound were to go away tomorrow, I still have maintained my ability to diagnose and come up with a differential using palpation and the conventional non-high-tech measures as well.
Of course, and you know that's what you're trained in, and so you want to rely on those.
Yeah.
Yeah. So on the sidelines, you've also worked with an array of other practitioners. What has that experience been like for you?
I think I have been really blessed. I have been very fortunate to have always worked with consummate professionals. When I was just out of fellowship and I first started in practice, I worked with an orthopedic surgeon that you may know, Dr. Rob Jones, and he is phenomenal, you know. And and he set a high bar, by the way, but as I've gone through and I've been in practice, it's been really, I've been really fortunate in that all of the orthopedic surgeons, all of the athletic trainers that I have been on the sidelines with have been very good. I think having a team approach is always best. When you have if you have the ability to have subspecialization where you have athletic trainer, physical therapist, massage therapist, sports medicine, and orthopedic surgeon, that is great. But like on the high school sideline, it's athletic trainer and myself, and that relationship has been good. It's we're colleagues. There are things that I defer to them with, and there are things that they defer to me with. I tend to take the approach, and most of the surgeons that I work with tend to take the approach. If you need me, that's not good. And having a support team that is there that can handle the things that don't really need the physician there is a good thing. Now, that changes or stands on its head when you get to the collegiate and you get to the professional level, where, yes, we have to be there to be the ones who are making the decision, who are making the evaluation. But 9 times out of 10, even though we are there, the decision finally comes to us. Even even in those situations, I tend to look to my trainers and my partners who are there to say, okay, this is what I'm seeing. What are you seeing? And make a call from that standpoint.
So, all right, and then in the clinic, is that, yeah, I hear you talking about your partners, the athletic trainers. There at Emory Sports Medicine, are there other practitioners there also?
Yes, we have again, absolutely. I am a big Emory fan. I know that this is not the norm, but the setup that we have, I think, is the ideal, is opportune, in that in the sports medicine division, we have uh, as our clinical as the clinical support, we use athletic trainers because they understand the initial diagnosis and how to initially go about treating a sports medicine injury. No one is better at diagnosing and understanding the mechanisms behind a sports medicine injury than an athletic trainer, a well-trained athletic trainer. So that's our clinical support. In the clinic itself, we have surgeons, sports medicine surgeons, and non-surgeons practicing side by side, sharing x-ray equipment, so that when there is a medical issue related to sports medicine, our surgeons can ask us about that. And when there is something that is surgical, we can defer to them and ask them about that. And there is that collaboration, that collegiality. And then also within that is our physical therapy. We have physical therapy that is adjacent to, attached to, and that we have a very good rapport with. So when I have somebody who is coming back as a follow-up and not doing well or is doing well, I can walk down and talk to the therapist, or they can walk up and talk to me and say, this person is doing that. And there's a lot of cross communication and really collegiality and partnership that goes on between the clinical assistants, the physicians, the therapists, and all of that coming together. And I think that when those relationships exist, that's when things are the best. And that's something that I feel outside of the clinical area when I work with the NSAF. That is the type of environment that is there, where we have different subspecialties that are there from sports medicine. We all work together and we all cross communicate. And it's a great environment for us, but the patient gets the best care that way.
And do you see sports medicine clinics expanding to those more of those subspecialties?
Um, I, I would have said pre-COVID maybe, but COVID has turned everything on its ear. But yeah, I think more and more people are seeing that having a not because I don't want it to sound like it's subspecialized and you're getting into silos, but having the multidisciplinary um, or multi-subspecialty co-locating is gives you better outcomes in that when you have a um, very good therapist or a very good athletic trainer or a very good physician, they are limited by the amount of they're limited by their expertise. Once it gets out of their expertise, they have to then defer to somebody else, and that can compromise the ability for them to give that overall good care. It's when they're able to partner with somebody that care maintains and gets to the next level. If you bring people together, that can be the ideal, but it's expensive to do that. Not everybody can. So it's at least, I think, if it's not the coming together of those clinics, it is definitely that people are setting up their networks where they have the reliable therapist or the reliable trainer that they have the relationship with, and they know do good work that they can say, okay, I've made the diagnosis. I want you to see this person specifically, or I've made this diagnosis. I want you to see this physician. So the care keeps the level of quality of care maintains its consistency.
Here and there are some maybe concern with if communication. There's a level of communication where I've experienced this on the other end of it. We're getting referrals from the doctor or the physical therapist, where it's the patient client who's coming to me with the information. And they don't always understand what what information they're transferring. So I can see how if you can consolidate more of these into more of a singular space where that communication would be more effective.
Mm-hmm. Mm-hmm. Or at least if it's not a single space, at least have a consistent communication stream where you know that you like for me whenever I see an athlete from a high school, I always text the athletic trainer and let them know. Okay, I saw them. This is what I'm thinking. Let me know if you have any questions. When I refer to a physical therapist that is outside of Emory, I usually shoot them a text and say, hey, this is what I saw. This is what I'm thinking. Let me know if you have any questions. And tell them to communicate back and forth with me so that level of, because yeah, we all have had that experience of when a patient comes in and says ABC, but their body is telling you DEF, and it's like, okay, that just doesn't make sense. And having that, making sure that those lines of communication are established and maintained.
Great. Well, speaking of communication, I'm going to pass it over to Greta to do some audience Q&A. So it looks like we have some questions that they're interested in learning from you. So let's do that.
Hey there. So got just a couple questions that people would love to know about. First of all, I wanted to ask about time frame as far as BMAC and PRP treatments go. How close to the time of injury do those need to occur in order to be effective? can they work on something that that happened years ago? Is there like this possible tissue regeneration if somebody's been dealing with an injury for years? And to extend on that, I know you talked about PRP being really effective with tendonitis and things like that, but does that also work on ruptures? So, loaded question.
No. I think it's very good. There is a debate, again, with regards to how you use the biologics. In my hands, and my philosophy is you use biologics to treat chronic injuries. Okay, they are not as effective at treating acute injuries. However, if you have, like that last piece that you talked about, ruptures, there have been a couple of studies that show that when you are doing a surgical repair of a rupture, using PRP can help that to heal a little bit more quickly. And when we talk about healing more quickly, it takes, most of us who deal with musculoskeletal injuries know that it's going to take 4 to 6 to 8 weeks for muscle, bone, tendon to heal. That's what we're working with. When you do PRP, we're not going to decrease that in half. We're not going to make an Achilles tendonitis magically repair itself. But if you've had an Achilles tendonitis that has been going on and you've done the conservative treatment and that conservative treatment is not working, that is when I have found that doing the biologics, especially PRP in the tendons, can help you to get to healing. When you talk about tears, ligament tears, it can, again, it's a tough, that's a tough one because most of the examples that people have of tears being healed are not, that healing is not confirmed by observation or by MRI. It's confirmed by functionality. So like a distal syndesmosis, if you have a high ankle sprain, you know that distal syndesmosis has been at least partially torn. Doing a PRP injection in there can get you back to activity and function in about half the time than it would normally take you to get back to function. But if you're talking about a hamstring strain, doing PRP into a fresh muscle hamstring strain is not going to get you back any quicker than, has not been shown to get you back any more quickly than using your normal modality.
Okay, so I'm gonna just be a little bit more specific in that line of questioning. So, and this is coming, I'm actually curious because this is my personal experience. So,
Got it.
Achilles ruptures.
Yes.
They're years old. I've got two. One's 17 years old. One's 3 years old.
Mm-hmm.
Well, you talked about how the healing is, you're basing it on functionality.
Yes, ma'am.
Whereas, yes, I know those Achilles are reattached. They were sewn back together. They're fine. Do I have calf muscles that work? Not really. So like in an instance like that, is there do you see benefit?
No, and that's the tricky thing. And again, my perspective, my perspective plus the literature backs me up here. There is no evidence in the literature that when you have something like that, an old injury that has been repaired, that doing the injection is going to, doing a biologic injection is going to then afford you the functionality. If the issue is that the construct or the structural integrity is not where it needs to be to allow you to strengthen, then yes, doing a PRP injection or doing a biologic or a series of biologic injections can allow that regeneration of the tendon to give you the structural integrity to then strengthen, etc. But if you have the structural integrity, you know, it's putting PRP into a structurally intact tendon doesn't make it any more structurally intact. It's structurally intact. You can't make good better from that standpoint.
Got it. Okay. We have also a question regards to just at what point do you send an athlete in for a medical evaluation? When should a coach recommend that a student be having a medical evaluation done? What are the kind of signals that pop up that go, yes, we can deal with this on the side of the field, or no, we actually need to send you in?
Yeah, it is, you know, it varies in that it varies on the setting as well. In when you, I'm in my mind, I'm going through, well, clearly there are the huge red flags of if a player is down and is not moving, they got to go in for a clinical exam. So I'm going away from the traumatic emergency, have to send them in. But in general, it is with an athlete getting something evaluated. The ironic thing is you can't necessarily use pain because pain tolerance varies. You know, somebody can say, oh yeah, I have no pain whatsoever, and they're playing on a completely broken foot. You know, and other people, they have a hangnail, it's like, I can't put my weight on. And so pain is out the window. It's more if the symptoms that they're having are one, compromising function, and two, are persistent. In that, yeah, you do something and they can't, quote unquote, shake it off within a day. It's not, well, yeah, it's because a lot of people are like, yeah, this has been going on for 3 weeks. It's like, why did you wait 3 weeks?
Right.
But, and it is, I think it's that one, the compromise to function, two, the persistence, and three, trust the athlete. 9 times out of 10, you'll look the athlete in the eye or the person in the eye and say, you know that this is something that needs to be seen, right? And they're like, yeah, I know, but I just don't want to go. You know, like what Tom was talking about earlier, people worry that if they go to a sports medicine physician, they're going to say, okay, you have to stop doing X, Y, Z for 3 months or don't ever do this sport again. But the majority of people, when they come to see me, they knew that they were supposed to have come. They knew that, but it is. So those 3 things is what I would say. One, the compromise of function. 2, the longevity, it being persistent. And 3, trusting the athlete and asking them, yeah, do you think this is something that needs to be checked? And they will 90% of the time tell you, yeah, I need to, but I'm not going to go, or something like that.
You tend to be the expert of your own body, and you know. Somebody else to put you on the spot to make you admit it, right?
Yes, yes.
All right. One final question. I know your time is limited and you have to go. But as far as portable ultrasounds and x-rays, price points, things like that, do you have specific recommendations?
And again, I'm putting on a disclaimer. I do not get any kickback or money from this company. The Butterfly, that is what Tom was referring to, the Butterfly ultrasound. To me, I think that has been the game changer, and that it's portable, truly portable in that it's just a probe and you can attach it to an iPhone, you can attach it to an Android, you can attach it to a iPad, and you get good quality resolution that you can use for diagnostic purposes. You can use it in, because I have one that I use in clinic. I don't use our $80,000 machine as much, because this one I can take from place to place. The big thing before you start thinking about going out and getting an ultrasound, you got to understand that you need to know how to use it, you know, and that's a steep learning curve in that if you, it's for a massage therapist or a physical therapist, you know, you wouldn't just go out and buy Graston tools or a dry needling set without going and learning how to do that. And that's the thing that I always caution people about. Make sure that you, if you're going to go out and purchase, you got to do the background to make sure that you can use it. And that Butterfly is 2000, it's under 2000, it's $19.99, so just under $2,000. And it is, if you use and know how to use ultrasound, it, as Tom said, is a game changer. You can use it just about everywhere you go, and it can be a helpful tool.
Dr. Mason, I'm so grateful to you for sharing your time and knowledge with us today, and for being out there in a non-invasive way, serving these athletes. Very, very grateful to you. So thank you.
I would like to thank you guys for, Tom especially, for coming up with this format and this idea. I think it's great. Getting this information out there, getting different points of view, and yeah, furthering just the understanding of what's going on. Thank you for inviting me.
Back to you, Tom.
You're very welcome. And yeah, thanks again for your time. Wait for your patients. I know you have to get back to them. So I'm gonna let you go.
Hi, thanks, Tom. I'll see you.
You're welcome. All right, so just a reminder that we are making up last Thursday's Zoom session, and that'll be at 3 o'clock today Eastern with Matt Devins, our athletic trainer. So we can learn more about what Dr. Mason is talking about with their diagnostic skills and what they get up to with college and high school athletes. So I know we were having Zoom issues earlier, so I didn't get a chance to set up the after session yet. But if you're interested, we can do that at, let's say 12:20 Eastern, and I'll get that link on the Facebook page to you, assuming that Zoom is all working well. And then just a reminder that little business, we have a raffle going on at the end of this week. So make sure you're catching all these interviews for that. And we have some great prizes for that, including from Altus, the 6-month membership and 12-month membership to their 360 digital video library. Earbuds from Jaybird and JLab. Signed books from, we have Nancy Clark's Sports Nutrition Guidebook, The Trail Runner's Companion by Sarah Lavender Smith, Anatomy of Sports Injuries by Brad Walker, and also a sampler pack from Honey Stinger. And of course, big thanks to NSAF and athletic.net to helping us put this on. So we'll see you again at 3 o'clock, if not earlier at 12:20.
Don't forget to check the Facebook page for the link momentarily.